Hi, everyone, and thank you for joining us today for the Navigating Ethics in Elder Abuse, Building Stronger Multidisciplinary Decision Making. I'm Marty Washington with the National Clearinghouse on Abuse in Later Life. Thanks for joining us today. I want to start off by giving a nod to the Office on Victims of Crime for funding this webinar and remind you that any of the opinions, information, comments you hear today are those of the author and do not necessarily reflect the views of the Office on Victims of Crime or the Department of Justice. And just some housekeeping. If you could please keep yourself on mute unless you're speaking, that would be great. Cuts down on background noise. Also, if you make sure that your name, I see everybody's got their name on their square. It really helps if you ask a question that we can call on you. Use the chat feature if you have questions. We'll be keeping an eye on it. And if you have any technical issues, please email me at mwashington@ncall.us. And before we get going, I'm going to just turn it over to Kylin. She has a quick announcement.
Hi, everyone. Just wanted to announce that if you have any questions about the webinar, or if anything comes up for you, please feel free to send us a technical request form, letting us know what your question is, or if you have any connection or any issues in regards to furthering the knowledge on the topic or on anything that comes up. So I'll put that link in the chat.
Okay, thanks,
You
Kylin.
mean after the webinar is over, and if you, in reflecting on the webinar, not questions for today's webinar during the webinar?
Yes.
Okay, thank you. And with that, I am going to turn it over to Dr. Sheri Gibson. Thanks for coming today, Dr. Gibson.
Thank you for having me, and it's great to see all of you on the call. I look forward to presenting some information to you, but also since we are a small group, I always find that the learning is a lot richer if we share and have a discussion. So I welcome any questions along the way. I'll also try to do a good job of inviting you to ask any questions. So I'm going to go ahead and share my screen first here. Okay. Is everybody see the slides?
Looks good.
Okay, wonderful. So I do think, thank you for inviting me to give a talk on this important topic. Just a little bit, oh, I guess I need you to go through some slides, don't I, Marty, or?
I did them. You can
You already
see
kind of did
slide
this?
4.
Okay, sorry, okay. Very briefly, I don't want to say too much about myself, but I am a psychologist. I identify as a geropsychologist. All of my training has been in geriatrics or the field of aging. I am on faculty at the University of Colorado at Colorado Springs, and have done a lot of things in my career, continued to serve on many national and local and regional committees. But I think one of the most, I don't know, the most important thing I've done in my career has been to be the founder of the Pikes Peak Elder Justice Center. And so I am here on behalf of the Justice Center, and you all probably know my colleague who is the coordinator for our MDT, and the facilitator, his name is Chris Paulton. And so Chris is actually not on the call right now because he is helping. We have a gentleman that he's helping place in our shelter program, and was needing to coordinate that. So I don't know if he'll be joining us soon, but he may not, he may have gotten tied up with that. It's always boots on the ground, as all of you know so well. So for the past several years, our multidisciplinary team, actually, we've been, I think this June will be our 3rd year of having the multidisciplinary team. And for the first couple of years, I facilitated this team. And now Chris pretty much does it on his own, and I'm just a backup when needed. But one of the things that I've noticed on the MDT, and I've noticed this throughout my career sitting on many geriatric teams, is, the tension that can come up around ethical decision making on the team. And so today I'm hoping that, we can I can expose you to what are some of these dilemmas that come up. I'm sure this is all going to be very familiar to you because you also see similar dilemmas on your teams. How do we enhance that collaboration between disciplines? And then what are some of the ethical frameworks that I can share with you that would help you kind of navigate those complex cases that, where to me, the big ethical principles, if we think about our principles, is really around autonomy and beneficence. And beneficence essentially is to do no harm or to remove harm. And sometimes these two really come into tension with one another. So, before I start an introduction, I had talked to Marty and Lisa about this. I wanted to start our time by bringing us kind of centered into the topic. So something that I do when I facilitate our MDT is I have a moment of mindfulness. And this really is just about some deep breathing. It settles our minds, it settles us into the place around the table. In our MDT, we have about 28 now professionals from various disciplines and agencies who come together every month. And so when you have a room that's full of so much energy and so much activity coming into the room, it's really important for us to just kind of center ourselves in what we're going to talk about today. One of the things that I do with the team is really centering ourselves into being good listeners, to being open to others' opinions, to always keeping at the center of our discussion the person who we're talking about. This is a person who some of us will never meet. This is a person who, we often refer to people as cases. And so there can be a disconnect sometimes when we talk about a case versus this is a real person that has a real challenge right now. And so how do we, remind ourselves of that that's so important. So I want to do that with you just for a brief moment. I'm going to lead you into what I do with my team. And I want you to allow yourself to either close your eyes or simply look down a few feet in front of you. And I want us to take a collective deep breath, breathing in deep through your nose and out through your mouth. Another deep breath in and out. And another. And returning to your normal breath, just take notice of your body for a moment. Notice if you're holding any tension in your forehead, if you're furrowing your brow, if your shoulders are tight, and just do any kind of small adjustments to allow yourself to feel a little more supported in your chair or relaxed, letting go of that tension that you might have walked into this space with. Taking a few more moments of breathing, again, settling our minds as best as possible. And now just slowly opening your eyes and coming back into your space, into this moment. Very nice. Good. Thank you. So today's topic is really about addressing elder abuse through this frame of a collaborative approach. And we know that it's been proven time and again, which is why you're all grantees, why we're all here, is that we know that when we have diverse professionals that look at an issue of elder abuse, that we are better for it. We can move these types of situations to a point of maybe resolution. We can work with very different disciplines in which we have social work and healthcare and law enforcement, legal services, all of these really rich professionals in the room that can give a different perspective to a particular situation. And while we know that that teamwork, that team that we have, does strengthen protections, and sometimes it strengthens a case that we can move towards prosecution even, that inherent in that is going to be some very complex ethical challenges and dilemmas. One of the things that I did during the first of the year is I gave every person on the team a kaleidoscope, because the kaleidoscope to me is such a beautiful metaphor for how we come into knowing this situation with a client who's been referred to our team. We come in looking through that kaleidoscope and we have one vision of it. But if we shift it just a tad, we get a whole different picture. And to me, the shifting of the kaleidoscope is really what happens in our discussions as a team. When I hear a perspective from APS, or I hear from the hospital system, or maybe the fire department, my view turns and I get a new picture. And every time somebody interjects and offers something, we get a new picture of that person's situation. And so I really think about that kaleidoscope metaphor in this case, in these situations and on a team. And also just, again, when we shift the frame, while that can give us an even bright or maybe a deeper understanding of the situation and of the client, it also can make the waters a little muddier, because the more people we have giving input, the more complex sometimes it becomes. So again, the key ethical issues for me is this balancing of autonomy versus protection. So respecting an older adult's right to make their own choices while ensuring that there have been safety nets put into place, or there are a certain protections that can be put into place. And also inherent in this ethical challenge or dilemmas that come up is the tension between confidentiality and information sharing. And that gets really tricky sometimes on teams. There might be certain disciplines or agencies that keep the information close and are reluctant to share information. And that can serve sometimes as a tension on a team, but it can also serve as a barrier. And so one of the things that I appreciate about the team I work on and what I've learned over the years is that we have to understand each agency's abilities and their own restrictions around information sharing and confidentiality. So for example, on my team, we have, elder law attorneys and legal services who are represented on the team who attend those meetings. So we have a practice of sending out the referrals a few days before the meeting itself so that those attorneys can do a conflicts check. They can make sure that they are not already involved in that particular person's case, so that, because if we don't do that kind of check, everything we discuss becomes discoverable if it does end up being, if it is a legal case. And so these are nuances that we have to be aware of as well. Other issues that come up for us is limited resources and prioritization. So really, we have to decide who gets which clients receive immediate intervention when our resources are very scarce. And also the legal and ethical obligations, addressing those gaps between what the law allows and what's ethically appropriate for an at-risk adult's well-being. And so these are some issues that, can certainly bring up a lot of rich discussion and some tensions on a team. When I think about ethics, especially on a multidisciplinary team, I think about a maze. To me, the maze is also a metaphor, right? Because it's this navigating ethical issues and elder abuse is really like finding our way through a complex maze. Each twist and turn that you see here represents another difficult decision between balancing autonomy with protection, respecting privacy while ensuring safety. These walls in the maze are built from our legal, cultural, and moral boundaries that often leave us feeling very uncertain about the right path that we should take. At times, we may feel very lost in that maze with no clear solution in sight. Yet, when we carefully consider each choice and we remain guided by our own compassion and justice, we can work toward an ethical resolution, ensuring that the older adults that we're serving who are living with, very important risk factors are safeguarded while their dignity remains intact. And to me, that's what we're here to talk about today is how do we navigate that maze, knowing that those walls are there for a purpose that help guide us to resolution. So some key ethical, considerations here are that we've already talked about. I've talked about autonomy and protection, respecting a person's right to make decisions while ensuring their safety. And of course, this is, this idea, this concept, this ethical tension is at the heart of adult protective services. Because people have the right to refuse services. They have the right to say no and to not answer the door and not answer our calls. And I think that when that happens and we can see the suffering that's being caused by not engaging with services, that can really cause a lot of angst for a team. And one of the things that I find helpful in a team is because we are all there working it together, sometimes it helps that people know we really are at a moment that we can't do much at this time. And I'm sure that you've had those discussions where there's not much you can do when the person is not engaging and is declining our help. We had a situation, I don't know if Chris has ever shared this situation recently. Well, I think it was last winter. We had a situation of a gentleman who he was without a home. I think he had been evicted due to financial exploitation, if I'm remembering the situation correctly, but he had been without a home. It was in winter. We found him safe shelter and we offered it to him multiple times. He was resistant, did not want to do it. He finally accepted it. He stayed in the shelter one day and then left. And within a week, he was found frozen to death on a bench. And this was a situation for us as a team that we really had to, first of all, we had to grieve the loss of this person that we had all tirelessly tried to help for a long time. And at the same time, he was his own decision maker and we had to respect his autonomy. And this also brings up the term dignity and risk. And for some people, there is a lot of dignity in the risk that they take. And again, that's attention for us. Confidentiality and reporting. So again, balancing privacy with legal and moral obligations to report abuse. Even though mandatory reporting in my state, although we were one of the last three to pass mandatory reporting, there's still a lot of differing, how should I say this? Even though people are mandatory reporters, they don't always follow the 20, once you know something, you report it within 24 hours. We're still having to give education to all sectors of people who are mandatory reporters to remind them, you still have to report this, even if it's not substantiated. And so some of that tension for a lot of people is, I don't want to make a bad situation worse, or I think that somebody else will do it because other people are involved in this person's life. I don't really know if something's going on, so I don't want to cause more trouble to the individual. These are all very rational and reasoned ideas. And we also have a legal obligation to do it, right? Family dynamics, I think, are some of the more challenging situations, navigating those complex relationships with family members, especially when family members may be the perpetrator or may be the influencer of the older adult or the at-risk adult. And then trying to allocate our services, addressing those systemic barriers. One of the things we've been working on my team is data collection. I'm sure you're all trying to figure out, how do we track what we're doing? How do we show the efficacy of what we're doing and the impact that we're making? And one of the things that we're tracking are barriers. What are the barriers systemically, and what are the barriers of the person that get in the way of resolution or them being able to access resources? And of course, funding is at the top of, for many of us, is one barrier that we have. We have very limited resources. For us at the Justice Center, we had some grant funding that we could actually put people in hotels. But as soon as that funding runs out, we're no longer a resource for that particular service. And so how do we sustain ourselves? How do we do that is always a big question that we're asking in our communities. So the importance of autonomy really is, I think, at the center of so much of what we do on a team. It's a fundamental human right, especially in Western culture. Autonomy, we always err on the side of autonomy. And thereby we empower older adults in ways to preserve their dignity and self-respect. We have some ethical frameworks that prioritize informed consent and participation in decision making. And I think that that's really important. It's important always when I'm on the team, I'm constantly asking, I ask two questions. You'll always get the same questions from me as a geropsychologist. Who is the decision maker? And what do we know about this person's cognition? Those are important questions to know, because we need to understand the context in which a person is able to make their own decision. And we always want to make sure that we know who the decision maker is for that person. One model that is mostly used, so this is a model that's used in geropsychology, but I have presented this in numerous settings, which really translates to any setting and any group of people making ethical decisions. And so this is called core opt. And core opt is kind of an acronym to help us think through an ethical decision. So we want to clarify the issue at hand. So I'm always thinking, what's at the heart of this? Is it confidentiality? Is it autonomy? Is it we're being overly protective? I'm always thinking about, what is the issue that is here that we're struggling with? What's our obligation to interested parties in this person's life? So I really my feathers get rustled when I hear the word stakeholder. It's just one of those words that I don't like in our field, but it's the word that we use. I like to use partner, but this is really anybody who is involved in that person's care, in that person's life. What are our obligations to those individuals? So do we have an obligation to the family member? Do we have an obligation to the APS worker, or maybe it's the hospital social work discharge person? What are those obligations, if any? Is it a legal obligation that we have? What are our resources, both ethical resources, legal resources? We have to examine our personal beliefs and values. And this is something that I talk a lot about on various teams, is that we come into this work with our own backgrounds, our own histories. And I'm sure I assume, I guess, that you've talked about this before, but I think it is important to remind ourselves that I walk into this situation, and really when I say situation, I'm assessing risk. That's what we're doing at the heart of our team meetings, is we are always assessing risk. Well, my frame for assessing risk is shaped by my training as a psychologist, my training as a geropsychologist, my experience and how long I've been doing this work. And if you go back even further, it's linked to my own family of origin. How did my family members interact with aging parents and grandparents? Because all of those things bring us to this moment when we're assessing risk. So I kind of think about this on a spectrum. If you think about autonomy on one side of the spectrum and protection on the other, when we're assessing risk, I'm going to have a bias towards one end of the spectrum or the other. I tend to lean towards autonomy. I want everybody to live their best lives. I want people, even if they're taking risks, I want them to do this as independently and as autonomously as possible. The problem with that is I have a blind spot. I may ignore important red flags because I am much more on the autonomy side. Conversely, I've been on teams where people are very risk adverse and they tend to be more protective. So for example, you have Mrs. Smith who's had 3 falls in the last month, and you'll have somebody on the team say, we need to put Mrs. Smith in a nursing home. She cannot live independently. And that is usually, in my experience, has been the medical provider. But then you have the social worker who says, now hold up. I come at this from a least restrictive perspective. So what if we put other protections in place for Mrs. Smith in her home? Let's clear paths. Let's, get a life alert. Let's do other things that can prevent falls and see if she can, manage with some extra supports. So again, when we're on a team, you may have people who tend to be more protective, or people who turn a blind eye to some red flags. And what we want to do is, as a team, come together and say, where can we come in the middle here? But know that when you hear that, when I hear it anyway, when I hear people being kind of on those extremes, I always remind myself that we come into this discussion with those biases and with our own training and with our own experiences. And so it's important to be open to that's how we operate. And so I always like to engage in that reminder with my team, so that it brings awareness to our part in a discussion, if that makes sense. I'm just curious, I'm going to pause for a second. Does anybody have a comment about that, or an observation yourself, or when you think about it in your own experience of coming at a risk assessment, how does that resonate for you, if at all?
Hi, I can speak. I am an adult protective services supervisor. And
Great.
we're going to come at it from the angle of autonomy,
That's right.
because that's a social work principle. So that's where we're going to start. Now, of course, if a person has dementia or some cognitive impairment, you know, and their decision maker is not making good decisions on their behalf, then we're going to go for a more restrictive intervention and more of a protective factor. But that's my default is autonomy unless the person has been declared incapacitated by the court.
Right. And so you work from, if you were thinking about the spectrum, I start at autonomy and we work incrementally towards protection.
Correct.
Based on the information that we're getting, what we know about the person's abilities, resources, all those things, right?
Yes.
Yeah, that's great. And Stephanie, do you find that there are kind of what I was talking about, that people come at it from those different viewpoints, and you will have people on the team that kind of, instead of starting at autonomy, working our way towards, that they start at the protection side?
Yes, I actually have one of my workers actually comes at it from the protection angle, and I have to work him backwards sometimes. So yes, there are people that come at it with that protection bias as well, even if they are an APS. Just because I think that might be, you know, from your own personality or your own beliefs, like you were saying, your own personal beliefs that a person should be protected. So, or it could be cultural because the person I'm referring to is from a different country. So,
Okay, yeah, absolutely. All of those things are so important to hold at the same time, simultaneously hold all of those things together so that you can have a better understanding. And I think that that's where, you know, when we are overworked and stressed out, we can very easily turn towards a lot of judgment towards our team members who don't get it, like they just don't get it. And I think that this also impacts our ethical decision making. So I'm going to talk a little bit about this, I think, at the end, or if I don't, I'll say it now. Part of our ethics is also to take care of ourselves. When we come into risk assessment, and if we are stressed out and burned out and weary in the work, we're going to tend to be more rigid in our ethical decision making. And so ethics is to take care of ourselves so that we can be the best stewards in our decision making for this individual that we're trying to assist, right? So let me move down the model a little bit more here. The O stands for coming up with options, solutions, and also forecasting what can be the possible consequences of this either recommendation, guidance, intervention, and then putting a plan into practice, and then taking stock and evaluating the outcome of what we've done and revising that as we might need. Because we might think, like, for example, I'll just give the example I was just using, you know, let's put in some additional supports for Mrs. Smith in her house and see if this works out. And then let's say a week later, she ends up falling again, is in the hospital, and is also found with some dehydration and starts to, starts to decompensate. Now we have new information and we have to say, okay, her status has changed. Now we've got to revise this plan and we've got to reevaluate what happened here so that we can take the next step. So it's a constantly going back and forth and evaluating what we've done. The duty to protect is also can present some ethical tensions. So when protection takes precedence over everything else. And so these are cases, as Stephanie mentioned, cases involving cognitive impairment or where coercion, the the psychological component of undue influence, with most of you are familiar with, may limit one's autonomy. Protective interventions are necessary to prevent harm. So we may have to move towards getting an emergency guardian or emergency conservator in the moment in order to stop the harm while we figure out what's the long-term implications. And then also thinking through the legal and ethical frameworks, adult protective services, for example, to give us some guidance around what's our, what do we need to do legally here in this particular case? Because sometimes that does take precedence, and we can't, we can't get around that. We just have to protect the individual and the situation. So there's some strategies we need to think about for how do we balance care, and I'm going to call that care, with autonomy. So one is we want to provide as holistic as possible assessments of the individual. We do that through evaluating their physical, their cognitive, emotional well-being. And that can take, there are multiple people who can do that. If you have medical providers on your team who can offer some insight around that, if you have behavioral health that can see the person or who have seen the person, and if you need to get, a cognitive evaluation to really get a whole picture of the individual and what their abilities are and what are some of their strengths or challenges, that can help us in balancing that care with autonomy. The collaboration is, very important. So engaging our members for specific contributions. So for example, when I'm on the team, and you may notice this on your teams, that certain disciplines will be talking more than others. This is a part of team process. So when I have my students, I have my doctoral students sit on our MDT as really part of learning team process and learning decision making on a team. And part of that is who dominates the discussion and who is quieter in that discussion, who cuts it off and who initiates. And the process of team decision making is really important, because what I like to do as a facilitator is draw in the people, or draw out the people who are quieter. And some of that is that people don't feel confident about what their role is on that team, or they don't feel confident to speak out. Some people are just more introverted or more quieter, don't feel comfortable. So I make a point to draw out. So I might look to maybe our Silver Key Senior Services, which is a service agency here, and say, when you're listening to this, do you have any kind of input that would be helpful here? Or do you think that we could look at it in a way of maybe we engage Meals on Wheels? What are your thoughts as you're listening to this? Because I think you have something you might want to share. I have a feeling that senior services would be a part of this. And so it's a way to make sure that we understand the contributions of all the disciplines. One of the things we do in our team is every meeting, and Chris may have shared this, we have a member of our meeting give a 15-minute didactic about their discipline, about their agency or whatever it is, so that we all learn who is at the table. Also empowering people, so providing educations and resources to support our decision making. I've leaned heavily on InCall's website for information. I've shown videos from the cache of videos that are available through InCall to help us, kind of build up our own knowledge and resources. And then also thinking about, as Stephanie mentioned, cultural sensitivity. How do we tailor our interventions and around an individual's values and preferences and what we understand them to be? And so as a psychologist on the team, I might say something like, what role do we think the trauma of this moment, but knowing this person has had multiple traumas in their life, what do you think that impact, how does that impact their ability to engage with services now? And so I like to ask the question of the group to get them thinking about it. I don't need to educate the group. I want to be educated by how the group thinks about those things from a cultural framework. So let me give you a kind of a case study, if you will, to help us think about this and frame it in a way that could be useful to you, I hope. So this is Mrs. Johnson, 82-year-old widow with early stage dementia. She's recently made several large withdrawals from her bank account. Her bank teller notices that her grandson, Mark, has been coming to her with at the bank, appears to be directing her transactions. So that teller alerts APS, suspecting that there could be some financial exploitation. When APS interviews Ms. Johnson, she insists that she trusts Mark fully. She states she's willing to give him money to help with his own financial struggles. However, the cognitive impairment really does raise some concerns about whether or not she can make an informed financial decision. And so thereby the dilemma lies in balancing her autonomy with the right to gift money with the need to protect her from financial abuse, right? So the ethical questions that could come to the team in this particular case is, should Mrs. Johnson's wishes be respected, or should intervention occur to prevent further exploitation? So that's kind of the question. And how should APS address the exploitation without damaging, I have mother-son. Did I say it was an adult son or a grandson? I think it's a grandson, right? Was that anyway, how do we understand the dyad here? And we want to preserve that if at all possible, especially if Mrs. Johnson is denying any wrongdoing. Like she's saying, I want to help him, it's okay, but we also know she has some cognitive impairment. So if we think about a resolution approach, we might be coming at it in these multiple ways that I think about. So one is, do we need to do a formal assessment of her abilities? Would she agree to do a cognitive assessment? We want to provide Ms. Johnson with some information about, protecting some strategies to protect her assets. Maybe we want to engage her in a conversation about how much is too much money. If Mark asked you for money, what would be a limit for you? Is there any limit? Is there any time where you don't want to you don't want to help him financially, but you feel like there's going to be some kind of reprisal or consequences, negative consequences to you? So we want to really talk to her in a way that is both open and non-judgmental, but understanding how she thinks about this relationship and how are there any thresholds by which she would think this is something I don't want to do? And then we want to engage our team, including social workers, financial advisor, if you have one, legal counsel, to assess that risk and explore what options could be available to Ms. Johnson. And again, some of this is going to depend on whether or not Ms. Johnson says, yes, I'll do an evaluation. If she says no, then we pivot in a different way, right? So we want to explore what those options would be in either scenario, and then do what we call proportional intervention. So does the intervention match what's going on? So if Mrs. Johnson has capacity, we want to support her autonomy, but encourage her to maybe consider some safeguards, such as maybe she appoints an independent fiduciary. If she is found to have capacity, but she also still has a dementia process, we can educate her that your dementia will likely get worse over time. And so what are some safeguards we could put into place now to protect your assets or to give you some financial assistance, you know, in terms of either supported decision making, or maybe it's powers of attorney, thinking through those different things. And then if capacity is diminished, we'll want to consider more legal protective measures. Could be as restrictive as conservatorship, but it may not be. It may be, you know, is the grandson her POA, her financial POA? If not, does she have one? Who might that be? And so really, this is the resolution approach that we'd want to take that's very holistic. It engages what we know about the person's abilities, what is the education we can do, how do we engage the multidisciplinary team, and then what's the intervention that's going to be most proportional to what we know. The other thing that I think about is just increasing our training. I think it's so important. Like Stephanie, what you're doing with your caseworker is really important. About we all still need training all the time. We want to emphasize self-determination and empowerment in both from the social work framework and an advocate framework. For our law enforcement and legal experts, we want to prioritize public safety and those legal protections to understand them. And from medical professionals, including psychologists, behavioral health, we tend to want to be educated so we can focus also on the cognitive piece and health-related risks. We address these challenges through our collaborative decision-making, where the teams, our teams have to weigh multiple perspectives to find that ethical, balanced solution. Capacity assessments are really important. We need experts to determine if a person is able to make those informed decisions. And then obviously we have to evaluate what are some immediate dangers, while we have to preserve some dignity. So that's a risk versus a rights analysis. And the ongoing education and ethical training that helps us all. You know, one of the, I'll share with you, hold on a second. I'll share with you this book that I refer to a lot, especially around thinking about different cultures who we serve on our teams. And we don't want to make assumptions about what we may or may not know. But this book was published by the School of Nursing at University of San Francisco, at UCSF. And I'll just hold it up. It's called, I don't know if you can see that, but it's called Culture and Nursing Care. It's a pocket guide. You can find this on Amazon. But what I love about this book is that it has 26 chapters of various ethnic cultural groups that we may work with. And within each of those, it gives us very important information. So for example, I'm just going to turn to one of them. It talks about early ethnic identity and the history of immigration for this type of group, but it also talks about how do people talk about end of life decisions? Who does decision making within that particular group? Is it family oriented or is it person oriented? And that's very important because I've worked with people where they rely heavily on their family members to make their decisions. And it's less about what they believe is right for them. And so if we're coming at it from needing to understand that person's autonomy and putting emphasis on it when that person doesn't want the emphasis because that is culturally not okay with them, we have to bring in family members and we have to understand it. And so part of my education, when I know that I'm going to go out and assess somebody that a type of ethnic group that I've not worked with before, I have to educate myself before that. I need to know those particular things so that when I am engaging in conversation with my colleagues around the MDT, I can be informed, or I can educate all of us about that. So this is one resource that I really love. I don't know if you guys all got it down. I share this with all my students. I've used it for, oh gosh, over a decade. And I don't think I don't think they have a newest edition. I haven't been able to find one, but really recommend it. But you have lots of resources at your disposal. So let's talk about that case of Miss Johnson. What was the outcome there? So if Miss Johnson is deemed capable of making decisions or making informed financial decisions, the team may provide financial counseling and education to reduce any further risk. If she lacks capacity, let's say, for financial decision making, and Mark is found to be exploiting her, then we would look for legal steps such as maybe conservatorship, maybe a protective order that would have to be pursued. The MDT ensures that Mrs. Johnson's rights, dignity, safety are prioritized while addressing those ethical challenges that can be involved in that particular case. So some key takeaways here is that we do want to prioritize autonomy whenever possible. That should be the place where we all start. And I know that you've had, I'm assuming assuming that you've had some training in ageism, and how ageism also, whether that is something that is so, implicit, that implicit bias, it's something we're not even aware of, but the way that we see older adults, do we see older adults as wise sages who have a lot of strengths and a lot of autonomy, or do we view them as frail and fragile and needing a lot of care? That can shape how we intervene with people. Did you guys get invitation to be part of this ageism book club? And they were, I don't know if anybody got this invitation. It was a national thing. I don't even know how I landed on it. But the book that they read, and it's a novel, and it's very funny. I bought it in large print that my 82-year-old mother read, and I read it with her. It's called Aging Disgracefully, and it's hilarious. And it takes place in England. But one of the things that my clients, my psychotherapy clients who I've seen over the years, talk about how when people, even their medical providers, view them through this ageist lens, it shapes how they feel about being empowered in their own lives. And I think that that's so important for us to always come back to again and again. And that's why we have to prioritize autonomy. Intervene proportionally to the level of risk that we see. Don't over intervene. Give people a little bit of risk, a little bit of dignity in that risk so that we can see what is possible with some supports, the least restrictive intervention. We also want to use person-centered, trauma-informed approaches to those individual needs. And I believe some of you have probably had that kind of training. And if you haven't, In-Call has wonderful videos that I've used with my own team. And that collaboration is really key in resolving these ethical dilemmas effectively. So what's our call to action? How do we become better advocates for ethical elder care? We want to educate our communities about elder abuse, about these principles of autonomy, I think, and beneficence. Support funding. Obviously, if you haven't joined the Elder Justice Coalition, I suggest you do. Be a member. Write your legislators. I've been doing a lot of that myself. I've been using 5 calls in my own state and leaving messages about lots of things to my own legislators as a way of feeling, at least participating in this process, so that we can advocate for funding for ombudsman and APS, long-term care ombudsman. Foster partnerships to create safer, more equitable society for our older adults. I think California, their Elder Justice Coalition blueprint is like the gold standard. It's so beautifully written and so comprehensive. Lisa Nurnberg, we many of us have known her for years. She just is such an advocate in this area. And so these are ways that we can be involved at a bigger level from beyond our MDT. I've included some references here. Now, I've got a few minutes, very few. I want to, okay, let me stop sharing. I have two things I'd like to do if I can. I know you guys are on strict schedule. We are out at 1. Do you have any immediate questions, comments, observations? No pressure. Although I am a psychologist, I'm very comfortable with silence.
Just have a very quick, because you're right, we do have to get out, situation that I can briefly share. We have the situation of an dual diagnosis, intellectually disabled, mental health, younger woman, age 37, who has a legal guardian. The guardian is really not protecting her, so we're going to go to court and terminate that guardianship and have a public guardian, but that's not the issue. The issue is this young woman she's very vulnerable, puts herself into vulnerable situations of a sexual nature. So she was allegedly raped. And I say allegedly because there's still a police investigation. However, we have an extensive history with her, and this is like the 3rd time it's happened. So I believe she was definitely taken advantage of sexually. So we got into a little tiff with the police because they need for her to go to a forensic interview, which is great. We want her to go to the forensic interview. We want justice served. We want to know what happened. But at the same time, the local mental health case manager made her an appointment to see a psychiatrist for medication because she's been off her medication and she really cannot function without it. And she had threatened to kill her former psychiatrist. So it's been a while since she's had medication. So the appointment was on the same day. So we had to balance out, we at APS, and I was the one who sent the email to the police department. They were not happy, saying, hey, we have a conflict here. She really can't function without the medication. She really needs the medication. She's very vulnerable anyway. Is there any way we could get an earlier appointment or reschedule this appointment? Because it was like smack dab in the middle of the day, 2 hours away. Like why they set her up with a psychiatrist 2 hours away is beyond me. But anyhow, so the police were not liking that. And I would like to read, if I can find it really super quickly, my response about it. Because I said, I'll quickly say, my agency did not make the psychiatric appointment that conflicts with the forensic interview. The mental health folks did. As we are all aware, this person has numerous needs related to her vulnerability. Her mental health diagnoses and intellectual disability increase her vulnerability. It is vital that she receive psychotropic medication in order to function. She is a complete mess without it. We are not trying to make your jobs any harder. We appreciate the fact that you care for her very much. I think we're all trying to balance out the needs of the criminal justice piece, the psychiatric piece, and the housing piece because she needs to leave where she is. We all agree that she does not need to be where she is, and my worker is working with the mental health case manager on her move. So anyway, I did apologize. I tried to smooth things over, but that's just an example of trying to balance they want versus what she also needs.
Yeah.
So, but they feel like the forensic interview is protection, which it is. It definitely is. But we see what we're doing as protection as well. As
Absolutely.
vulnerability.
Yeah. it kind of, there's kind of and I know we have to go, but you can think about those hierarchical needs, right? The need to get her psychiatrically stable so that she could engage in a forensic interview is really important. And that she feels better psychiatrically to be stabilized. Um, those competing needs of everybody, but again, thinking about what is going to be in her best interest right now. It seems like it would be awful for her to be psychiatrically unstable. Just her feeling all the feelings that she's going to have in that experience. And so addressing what the immediate need is for her, and maybe even making a case to law enforcement like, look, she's got to be psychiatrically okay to be able to engage in a forensic interview. Those forensic interviews are very traumatizing. They ask them really hard questions. She's going to have to go back to those moments, detail by detail of what happened. If she is not psychiatrically okay, or that isn't addressed, you could do more harm to her by putting her through that. And that to me seems like a rationale for how do we respectfully engage with the different services and the different competing needs that are there. But I think ultimately it's her need to make this as humane as possible in a process.
Thank
Yeah.
you so much for coming.
Okay.
Yeah, we have run out of time. I will be sending the PowerPoint out to you, so you will have these slides. And as Kylan had said in the beginning, if you do have other questions, please fill out a TA form, and we will make sure Dr. Gibson gets your question. So we
too.
can get anything that is concerning to you, we will get it answered. But thank you so much for joining us today.
Thank you, everybody. Take care. Be well. See ya.